Good morning, everyone. I, Vishal Kapoor, welcome you for our monthly peripheral webcast from Mount Sinai Hospital in New York City. It's 8:06 Eastern Standard Time, and we would like you for welcome you again for the session of this month. Before we go into the lab, I would like to introduce to you our ever-expanding endovascular team. With me, I'm sure you guys know Sardar Farhan. He just joined us as a faculty here at Sinai. We're very pleased to have him. He was our fellow, but now he's our partner. And morning, Sardar, welcome. All right, before we go to the lab, one more thing I would like to talk about is our annual summit. This year, we have a little bit of changes, I'm sure, for the people who know, just to reinstate, and for the people who don't know. Our annual conference of peripheral interventions have moved from regular slot in June to back in April. It's called New York Endovascular Summit. It was formerly known as Link Mount Sinai, but now it's New York Endovascular Summit. For details, registrations, we recommend you go to the website nyevs.org and register. You can actually see the list of the faculty, the course. It's a 3-day summit as ever, with 1 day dedicated to the fellows, which me and Sardar will be leading, along with Dr. Guja and Dr. Han. And then the rest 2 days will be a core, hardcore live cases and lecture talks with a lot of interaction with world-class faculties, including Dirk Schreider, Tom Zeller, Marion Broadman, and other esteemed faculties from the United States as well. So for any other information, you can email us. You can go onto the website, register, talk to us, and we'll be more than happy to provide information. We would love to see you guys there. And for our peripheral live cases, you know, ccclivecases.org. You can view these cases on the archive section, live stream, send us emails, comments, concerns. So without further ado, we'll move to the lab. Good morning, PK.
Good morning. Luckily, welcome, first of all, everybody. And let me just scrub out. I would at least present everybody before we start. Can you put a supercore up? So it's a pleasure today to welcome all of you to the Cath Lab. And I want to thank all of you for your support. We got the statistics from last year, and the amount of people watching our live webcast has increased every single year to the tune of around 2,000 per case, which is unbelievable. And one of the requests was that we work. We always talk about our relationship with our surgical colleagues, and one of the requests was that we have more of the surgical input in our cases. And so we actually worked hard at trying to fill each one of the requests that you have, and we're thrilled to have one. First of all, a dear friend, and second of all, just an incredible interventionalist and surgeon, Dr. Rami Tadros, who's taken time out of his really, really busy day here at Sinai, along with his fellow Dr. Turner, who's kind enough to join us. We have a very interesting live case that really requires a multidisciplinary approach because of the decisions that need to be made before we get here. Before I go on, I want to also introduce Dr. Tadros, who's currently at the head of the table. Rami, just wave at the camera so everybody can see you. There's Rami. Dr. Karthik Guja, who's right next to me. Dr. Turner, who's behind me. We have Haroon Cameron, our current endovascular fellow. Ray Lascano in the back, our wonderful AV team. We have the good folks from Shockwave, and as well as from Gore here to help us. And we've got Elizabeth, our endovascular nurse, and Damien, our endovascular tech. So without further ado, since I made a lot about this case, I'm going to have our fellow go ahead and talk. And Dr. Tadros is really going to go over some of the challenges in decision-making, as well as in terms of, what is the best for our patient. So let's go ahead. Go ahead, Haroon, present.
Balloons.
Can you put up the slides, please?
Balloons.
We'll talk about
Next slide, please.
Supracortisan.
Hi, good morning. Our patient is an 87-year-old female with a past medical history of hypertension, dyslipidemia, and an ex-smoker who presents with bilateral buttock and thigh claudication that has now progressed to pain at rest. Her medications, as you can see, include aspirin, amlodipine, metoprolol, lisinopril, atorvastatin, and cilostazol. She had an ABI done at rest that showed an ABI of 0.54 on the right and 0.46 on the left. She had a subsequent CTA done that showed a subtotal occlusion of the left common iliac artery and severe stenosis. And severe stenosis of the right common iliac artery. She had an attempted intervention at an outside hospital that was unsuccessful due to inability to cross the lesion, and she was subsequently referred to Mount Sinai Hospital for further evaluation and management. Next slide. Thank you. So as you can see, the CAT scan shows an MLA of 2.5 on the right and 2.7 on the left.
So, I want to stop here because I want to ask Rami. I mean, we got a lot of time for discussion. Is that Rami? Cardiologists look at CAT scan different than a surgeon. I know that for a fact. And the point is, what we looked at is exactly what Haroon looked at. We looked at the mean lesion diameter. We looked at the size. We really don't look at the status of the aorta. So when you're dealing with this difficult aorto-iliac disease, you've obviously got aortic involvement. You've got total occlusion at the ostium, or possible. I mean, what are the things you look at from a CAT scan, and what can you teach us that we should be kind of having our eyes towards?
So I think some of the important things are the nature of the disease, the extent of the disease, whether it's calcific or not, and then if that calcium is circumferential or not, how involved is the aortic bifurcation. I think those are all things that you really have to think about. So going through them one by one, if you have extensive calcification of the distal aorta,
ECT,
and aortic bifurcation with occlusion or severe stenosis involving that region, you have to think about it a little bit different. When it's circumferentially calcified, heavy calcium, that's at risk for fracture, aortic rupture, or you can end up with a tear in the aortic bifurcation.
Right, that's the worry.
And so that's a serious concern when you have very calcific disease extending into the distal aorta, aortic bifurcation area. When we see that disease pattern, we start thinking covered stents. We start thinking.
So the planning process starts.
Right. You got to start thinking covered stents. You got to start thinking, am I raising the aortic bifurcation with covered stents, or am I going to consider using like an endologics device?
Right. And that's what a lot of people want to know about.
Right. So I think with the endologics device, you have to look at the remaining vessels. I think that you have to look at the external iliac, the remainder of the common iliac, to know that you can actually get the device into position. It's a 16 French device, so sometimes you can go in, you can pre-dilate everything,
right,
and still manage to get the device in. But if the access is extraordinarily tight, especially in the externals,
right here,
or in the where often we get hung up is either in the external or right at the iliac bifurcation, where you often have calcification at the ostium of the internal, which may prevent you from delivering a 16.
So one of the questions I always get, and Karthik always gets, is, when you look at an aorta on the CAT scan, it looks terrible, right? You've got plaque, you've got calcium, you guys see it all the time. Yeah. I mean, how much of that is taken into consideration when you do this? So for instance, saying this lady who has an occluded common, probably in the aorta had some crud. Right. I mean, when do you think about a CRAB technique? I mean, this patient obviously has, calcified externals, which we'll show them, and you saw in the CAT scan. Yeah. So probably not an ideal endologics case.
So I think
when do you decide how to treat the distal aorta or not to treat the distal aorta?
I think that the thing to keep in mind is what we're treating.
Right. The syndrome.
The disease, yeah. What the patient's coming with, right? So just because the aorta looks terrible or is shaggy, we really need to look at the lumen and know whether there's a hemodynamic obstruction there or not. We're not just treating the CT finding or the angiogram finding.
Which happens often sometimes. Right. Yep.
I mean, it may look terrible, but if the lumen's 8 millimeters and there's no gradient.
And she's a claudicant.
There's no need to subject the patient to the additional risk of, say, a CRAB.
Right.
And I think my point that I made earlier, which is that the access really comes into play. If you can easily get the device into position, bring it down onto the aortic bifurcation, and then balloon it with high pressure balloons, and really iron out the aortic bifurcation with a stent graft, I think it's a reasonable thing to consider when you have circumferential aortic calcification at the aortic bifurcation, or maybe a little more proximal to that, with involvement of the proximal common iliacs.
Got it. Great points. Karthik, question to you. Vishal, I'm going to ask Karthik, I want to ask you a question as well. Karthik, in terms of access points, and Sardar, you as well. I mean, how do you plan these cases so we can talk to, you obviously have a CAT scan, which is more than, and we'll talk a little bit about pre-op imaging, but CAT scan, with that, the anatomy, how would you have planned this case?
Bilateral femoral, for sure, but especially based on the CAT scan, I think it's very calcified. It's not occluded. I think it's partially occluded on the right side.
On the left.
On the left.
On the right was occluded.
On the right was occluded. So you can always take the access bilateral. So you have access on one side. As long as you have access on one side, you're protected against the CTO. But if both sides are occluded, of course, you have to go for a radial access. But I would not traditionally just do radial access for any bilateral iliacs. because even if, as Rami said, if you want to upgrade it and go to an endologics, or upgrade your case, which
Limits your
probably is,
options.
limits your, if you have a radial, then you're limited to it. You don't want to do that, and you don't want to get an access in full anticoagulation at that level.
Right, right.
And also, especially if you're doing a common iliac CTO, the risk of rupture, you want to have an aortic occlusion access, and radial limits you from doing that.
Although they have now a 10 French aortic occlusion balloon by Bard, but that's still not there. What about you, Vishal?
No, I agree with the plan. It's all about visualization and having a good view of what we are trying to fix. So if there's significant tight lesion on both sides, then radial gives us the extra eyes where you can inject and have an exact anatomy and define. But if the occlusion is, in this case, is probably severe, we'll see. In this case, you might get bilateral femoral and try to get away with it. But I'm more about like what you see is what you fix. And so if there is not much visualization, getting a 5 French or a 4 French radial just for visualization, I don't think is a bad idea if you have to. What do you think,
Okay,
Sardar?
Sardar, what do you think?
I think the obtaining, considering alternative accesses for such an intervention is crucial and important.
Can you play the fluoroscopy?
Especially in their case, where we got the patient referred from an outside center where they failed obtaining bilateral common femoral access. This gives you the first clue that it might be complex, might be challenging, might be extremely calcified. You might puncture into a dissection and you start your case already with a complication. So in order to avoid that, obtaining a radial access would be helpful to obtain first preliminary images.
Exactly.
As you did, Dr. Krishnan, now with this live case. And from there, you can consider obtaining bilateral femoral access using the roadmap technique, and have a good visualization of where you are entering into the skin and in the artery, and make sure that you get with a large bore access an anterior stick rather than a side stick.
Yeah, I agree.
This is a great point. So what initially Rami and I, Dr. Tadros and I had spoken was, let's try to get radial, and let's try to do it R2P, iliac. Yes, we can probably maybe do it. But when we saw the arch, it's a very high. You can see how the calcification of the arch, the very high bifurcation, or we should say, descending aorta from the ascending aorta. The arch is very steep. So therefore, we went with first we did the woolly wire technique with just a coronary catheter. Obviously, a great deal of difficulty to get up and over. Finally switched to a soft angle glide, and then soft angle glide there you see pops over, and then we're able to track it down. But then even tracking the pigtail down across that was very, very difficult. So when Rami, Dr. Tadros walked here, I told him, I think Rami, going to have to modify, because I can't imagine R2P, even though they're very slick sheets, great sheets, going up and over. If we do get in some sort of trouble here, to be able to manipulate a very bulky device across this may become a problem. So part of that is the discussion we planned together, because remember, surgical options are still viable on this patient. You could still do different axillobifems, aortobifems, fem after revascularizing the left side, which wasn't occluded. So it's very important for the cardiologist to have that discussion, because at the end you want the patient to feel better. But Rami, you can comment on the R2P.
Yeah, so I've done a lot of R2P cases. I've done both iliac and infrainguinal. I've gone all the way down to the ankle.
Right. Shorter people, right?
Yeah, and so, and I think our technology is not completely there yet. There's still a lot of limitations and a lot of difficulties with R2P, especially when treating infrainguinal. That said, this is a challenging arch. One of the things to consider here is the patient's going to be, the stroke rate, stroke risk. With the calcific arch, it's a serious risk that you need to consider. Just like when we do our TAVIs and you have a calcific arch or calcific valve, there's always that potential risk for breaking something off and embolizing. So that's a serious risk when dealing with the arch. So putting a 4 French pigtail is one thing, advancing a sheath is another. Could we do it?
Sure.
Likely. I mean, we could probably put that catheter, bury it down deep into the aorta, put a stiff wire, either an Amplatz wire or a Lunderquist, and get the R2P sheath to track. That said, we were able to get bilateral femoral access.
Right.
And so when you weigh the risks and benefits.
Exactly. And that's what we did. So we did an aortogram, and Karthik and Vishal, you haven't seen this, and Rami just saw this recently. So you could see the aortogram completely differs from the CAT scan. In the sense that the aorta, of course, it's shaggy, it looks terrible, but it's not something that you would necessarily say angiographically, I'm going to treat that aorta. It's a little narrowed at the distal bifurcation, but other than that, that's it. Second, you can see that the internal iliac, the common iliac is occluded on the right side. And on the left side, you obviously have a very diffuse disease, but it's really subtotal at the level of the left common, because we had a very difficult time wiring it.
It's very eccentric
and very eccentric, and the left external is also eccentric to the point we could not get the sheet through. So here's an example of the occlusion of the common, and you can see here how interesting that how the internal iliac is such a high bifurcation off the aorta there, or is that even a collateral? I don't even know. Rami would be able to tell us better. And you can also tell that the left common has a significant eccentric stenosis. You see it there very well, like Vishal said so nicely. So we did a fluoro-guided access, just injected, stuck it just with a needle. We could have done obviously ultrasound guided, but for the sake of time, we did fluoro-guided. And again, we did fluoro-guided on the opposite side, okay? And then had a real hell of a time getting the wire through that external iliac stenosis, as you can see. But we were able to loop the wire gently and then put our micropuncture sheath in, and then we're able to track a glide wire across it. Then we got up to the top here, very difficult to cross this area up top. So actually, this is the same technique we're using here to cross the external iliac. So we were able to cross, and then up top here, you can see that it looks very stenotic.
Wow.
And then you can see here when I inject from below, it actually behaves like almost like a functional occlusion, although you can see the little dye going out the side. So we went ahead and were able to snake a catheter through, and then put a supercore up. On the right side, myself and Rami were able to very easily actually wire the right side with a 014 wire. It's a CTO wire. Definitely the glide wire didn't go, but you can see the overlap is tremendous. And the question of that internal iliac or bifurcation when we do a stent is now going to become an issue because it's coming right off the aorta. And whether IVUS plays a role or not, I got to ask Rami. And then over here, so once we got through, we were able to get through the vessel. And now this is where we are, wires up. And I want to show you what's going on inside. We have two 7 French sheets in the groin. We have two supercore wires up in the aorta. We've got obviously one 7 French sheath on the left, does not cross the external iliac lesion. On the right, we've crossed the external iliac lesion, no lesion, we've crossed the external iliac, we're in the common iliac, crossed the common iliac. And I want to kick this to Dr. Tadros because he's sort of been the pioneer for sure in our hospital and maybe even in the East about using different technologies to deal with calcium, especially with his experience with the calcified aortas that they deal with in TAVR. So Rami, I mean, we talked about covered stents. We talked about, the aortic bifurcated grafts. Now, everybody talks about vessel prep for expansion. Mm-hmm. This is a scary area for vessel prep. I mean, I know you've done a lot of this, and we've done a couple of live cases with you. So, what's your experience, and what can you tell us?
So, I think that the device we're talking about really is a Shockwave lithotripsy device, mm-hmm. which is intravascular lithotripsy. The idea behind it is that you are fracturing the calcium and improving vessel compliance. That's the whole idea. And from our experience doing aneurysms as well as TAVRs and helping with access there, it does improve vessel compliance and it lowers the rupture risk, but it's not without risk. So in our recent series that we're going to publish, mm-hmm. 14 cases, combined TAVR and aneurysms, and these were, sub 4 millimeter lumens and placing 16 French or larger diameter sheaths. We had one vessel perforation.
Very good. The complex cases.
Yeah.
These are the highest complexity cases.
And with that, of course, you come prepared.
Sure.
You come prepared with your covered stent. You anticipate the problem in advance so that you minimize the risk to the patient.
And that's a good point for everybody at home. And Vishal, you can highlight this. Is like you got to come prepared. Like Rami said, just because you have the Shockwave balloon doesn't mean hey, I'm not going to rupture. Now I can put up my bare metal stent and go home. And I think the key is to have that prepared. Vishal, can you talk a little bit about the different covered stents that are available on the market aside from the stent grafts? I'm talking about the stents that are available.
Well, yeah, nowadays we have good technology stents available. We have the VBXs, the Gore, which are balloon expandable stents varying from different sizes. It goes to a smaller lumen sheath, and you upgrade a 7, let's say it's a 7.0 stent, we can go up to 10, 11 postal. We also have a wire-bound, which is a self-expanding stent, most likely used in the lower extremity. So, and we have other covered stents from other technologies as well. to be used. And so it all determines on the location, the size, the positioning, and the calcification. If you want to mark it directly at the exact point, balloon expandable are preferred. If it's the length and the elasticity, then self-expanding is preferred. So that's pretty much what the self are. You have anything to start there to add?
Absolutely correct. I mean, you have to ask your question. What I'm expecting to treat? Do I need radial stents? Do I need precise deployment? Do I need? Will I geographically miss the lesion, or would I extend the stent into the aorta, and then create a future problem for the patient? Therefore, your decision whether you're going to use a covered stent, balloon expandable or self-expandable covered stent depends highly on this, on the location of the lesion and the way it looks like. In your case, you have here a severely calcified lesion, so in the common iliac artery, so it looks like a balloon expandable covered stent would be the choice to have a precise deployment.
Perfect. Yeah, and just to add on to the point, balloon expandable, if you start from a slower size, always keep a margin for shortening of the stent. Nowadays, technology is better that it doesn't really shorten as much, but there's definite shortening. So that one thing you have to keep in consideration.
Those are good points, but Karthik, what if you were to compare the two available covered stents, or three now? You have Livestream. You have the. I mean, which is the one that you think fits in these type of complex lesions the most?
I mean, it depends on what sheet size you have. If you have liberal sheet size, I think you can go with any stent size you want. But if you're limited to something like this, where you want to put lower sheet size, you want to limit your sheet size to 6, or especially if you're radial, like Rami was saying, if you go from radial and you want to stent a calcified lesion from the radial, now you're limited to a 6-7 slender long sheath is not available. So you only have 5-6 slender. So you're limited to 6-fin sheath. So you have to go with something like VBX, which is limited to only 6-fin sheath. That too, not all. No, VBX can go through 6, but it has to be
depends on
the size of the stent. So
the
you
length
can go
and
on
the
to
size.
7/29.
7/29 is 6 French.
Where's our gore person?
Yeah, we can.
Is the VBX go through a 6 French? No.
Yeah, 7/20.
Not yet.
I think I use about 100 a week. So
yeah, that's what I'm saying. VBX doesn't go through 6 French.
No, 7/29 goes right.
7/29 goes through. Yes. 7/29 goes through a 6 French. 7/59
I can guarantee you that.
Yes,
100%.
it does.
Well, they don't recommend that.
they don't recommend it.
All right,
careful, 1 second.
Just to let you know, but it definitely goes.
All right, so what we're doing now is we're advancing the Shockwave balloon, and you're going to see the trackability of this balloon. Now, Rami, while we do this, I want you to just comment on that huge collateral, or interiliac, in my opinion, coming off the aorta, and whether choice of stent is going to make a play. For me, the way I look at it, if it expands well, I modify the vessel well, I balloon well, I may go with a balloon expandable here because of the fact that stent is so important. So before we do that, why don't we go over the Shockwave device?
Sure.
Who wants
to?
I
have a couple of questions. I have a couple of questions when you're done.
Okay, let's just go with the Shockwave device. Can you show the device, guys, for our camera crew?
One of the advantages of the Shockwave device is that you can actually expand the vessel at a much lower atmosphere.
Yep.
So the idea is that do we have an insufflator, guys?
Yeah, we do.
Let's attach the insufflator.
Insufflator, guys.
What the ideal pressure is around 4 atmospheres.
Yes.
So that way, 1, it minimizes the risk of vessel rupture. And 2, that actually allows the ultrasonic waves to pass through the balloon and at an effective rate. So once we've attached this, we'll go ahead and do a dilatation to 4 atmospheres.
So we're going to go up now to 4. This is what we always do.
And then
we did this last year in Link Mount Sinai. We did a beautiful case. Rami was on the panel while we did it. It was a fantastic case. Similar sort of very, very calcified iliac. So you see I'm going up to 4. I'm just at 4 now.
So PK, there's a question for the operator saying, you know how it is. I mean, I know you were probably lumen to lumen, but what if you suspect you were subintimal somewhere in the iliac and re-enter? Is Shockwave still advisable if you're subintimal?
It's advisable. You can do it subintimally, but in my opinion, and we've done quite a bit as well, is that Shockwave really works well when you're intraluminal rather than subintimal. Look, when you have eccentric calcium, even though the company says it works really well, I think it works best in concentric calcium. I'm not saying it doesn't work well in extrinsic calcium, but I don't think you're going to have the same rupture that you're going to have with a regular balloon where we go with this. Yep. So now Dr. Tartarus is going to show you.
Yeah, we have the generator there. That's going to actually generate the ultrasonic waves, and then we have this handheld device
the generator
that connects to the actual balloon catheter. So when we actually,
He's going to go up.
we're
Can you
actually
guys hear that?
activating the device now.
And you can see the proximal aorta is not expanded yet.
Yeah, and we have a total of 300 seconds of treatment time. So usually we'll do.
That's good.
All right. So,
Liz?
She feels it.
She feels it. Okay. So a 7 millimeter balloon at 4 atmospheres, and she's feeling it.
Okay, so it does 30-second intervals.
She's probably feeling the.
Oh, there's no hematoma, I hope. Yeah. A lot of what? Yeah, that's normal.
yeah. So, PK, just one of the viewers had a question. Just
2 cycles.
just stepping back. What if you were not able to cross with an 014
Would you
wire?
ever
Rami,
stop?
what's your algorithm?
He'll stop it.
Yeah, I think they're both looking at something.
okay.
Go,
So
Vishal, what
I'll
were you
just
talking
go over
about?
it.
Go ahead.
Sorry.
So if you cannot cross with an 014 wire, we usually try.
What's
with
the algorithm?
we just keep escalating our wires. So normally we use Confianza to start with. Normally a stiffer wire 014 because the regular regular workhorse wires are not the wires to be
It'll
used
stop on its own.
in common iliac occlusions.
Yeah, it stopped.
Then you can upgrade yourself to 018 or 035. Usually we move
down.
on to 035 very
Take a
quickly if the 014 fails. So 018 is usually not much of an option on our end. I think that's what PK uses to, and I think that's what you do, Vishal. But I don't know, Rami, from surgical standpoint.
Yeah.
Well,
The question is
one
from
comment on
014.
that. I always look at how this thing changes. So there it is. Oh, we don't know if that's flow or not, but we clearly have a. But the problem is you really can't see much of a flow. We tried both contralateral and ipsilateral. So what I was saying is what I do is I go through the occlusion with any wire that goes through the occlusion, right? So in the sense, so if it's an occluded segment, me and Rami, what we did was we took an 035 wire, went all the way to the aorta, okay? I can't even tell. So when we went all the way to the aorta, we couldn't cross the lesion in the aorta with the 035 wire. So at that stage, what I decided was, hey, you know what? This closes by fenestrations. Let's go ahead and do a 014 wire to find the fenestrations. So that's what we did. We did an 014 wire. It looks like it's
there's
open.
no flow.
Yep, now there's flow. So we use an 014 to cross, and a Confianza as well cross. You can see there's opening, but now you can see the collateral. Now you can see the difference between where the collateral is and where the vessel is.
Yeah, that's probably the internal.
Yep. So now the issue is what do you want to do here?
My personal preference here, when you have such a large internal, would to try to use bare metal.
Okay. So
We've expanded the vessel with the
so
with the Shockwave. We've improved the compliance. I think we should have a covered stent available
of course.
in case we rupture. But I would lean towards a bare metal stent just because of that internal. And we had a good response with the Shockwave.
So right now I'm going to walk the Shockwave back, and I'm going to go up with an 035 wire. Can you fix the sheet, guys? I'm going to walk with the 035 wire up, put a 035 wire through a support catheter. Again, I want to implore the cardiologists at home, and I think we have to learn from our surgical and radiology colleagues. These aortas are very, very calcified, very difficult to work on an 014 system if you get in trouble. Don't get me wrong. There are slick 014 stents. Things work. I need a catheter to switch. So there are slick 014 stents, but in this kind of very heavily calcified vessel where you might need to go with a balloon expandable covered stent, well, you know what? It's not going to track very well over an 014 Spartacor, as great as a Spartacor is. So take the time, switch out to an 035 wire, stay out of trouble, plan, predict your complication if there is going to be one, and be ready for it. Rail, yes? So predict your complication, there's going to be one, and be ready to pull the wire? Yes, sir.
There is a question from the audience regarding whether IVUS would be an additional tool to determine which kind of treatment you're going to apply for this patient.
Well,
That's
the
a very
ideal
good
thing is, it's a great question. We have a CAT scan. I'm going to pull this wire out. Give me the supercore. We have a CAT scan. Rami, when do you use Interop IVUS when you have a CAT scan?
I mean,
Okay.
I think
Oh, you have it.
if you're worried about dissections and things,
Yeah.
sometimes useful. If you're not sure if you're luminal or not, it could potentially be useful. But honestly, for iliac and aorto-iliac
If you have a CAT scan, you don't, right?
occlusive disease, I don't.
How about you, Karthik? What do you think?
Syringe for it.
So I usually use IVUS on any
second
iliac
ACT.
CTO.
I got it.
It's my standard way of
sense.
doing it. Every
Yeah.
iliac CTO I use IVUS. I just want to see if when I balloon it, how much of plane I have and how the plane is moving and everything, just to decide covered stent. For this patient, I don't know if I would define the bifurcation much better than what we defined here before putting a bare metal. That's my opinion. And Rami and PK have more experience than me, but that's my opinion. I would seriously see if that internal iliac is directly coming off of the aorta, or is it really branching off from the?
No,
Because she's a female.
It's coming off the proximal.
Right.
It's coming off the proximal iliac.
Common iliac.
Okay.
That's what it
So-
looks
But
like.
I think the important thing to also consider is her main complaint.
80 balloon,
Her main
guys.
complaint is buttock claudication.
8040.
So, but she has a huge internal iliac coming off from the contralateral side also, right?
Right.
So, especially if you have one internal iliac, she's female, is the risk worth taking
think
of
that-
putting a bare metal and close?
I think if it was simply
On my
thigh or
fine.
calf claudication,
Yeah.
I think that you could cover the internal iliac with greater impunity. I think given that her symptoms are largely gluteal claudication,
Right.
I think that if you can do without the covered stent, I think it would be better.
So Haroon,
Yes.
what was the size of the common iliac?
So common iliac was, I think 3.4.
What was it?
3.
Oh, no. Well, what was the size of the distal
Size.
common iliac? The size of the distal common iliac after the occlusion?
If you can
Like
just
a
pull up the
7.
slides for me, please.
I guess
It's
there
there.
was one
Why don't you
measurement
scrub
where
out
the
and look
mean-
at it?
Slide.
The mean was 4
So
millimeters. Yeah.
this is very important, guys. You see this? Because right now we're deciding on
about-
ballooning and
it's about
stenting,
7
right?
millimeters.
7 millimeters, okay? So that's very important. So what I want to do is take a look here. Do we go with an 8 or don't we not go with an 8? So you can see here. So you see it's coming off the side, it looks like, right? It's coming off the proximal common off the side. Very difficult. I don't think Ivis is even going to help you right here to see where it is.
That's right there. Yep.
See, it's posterior. So I think the internal comes up and around is what I'm assuming. So I think ballooning it with an 8 is going to give us more information. Would you go with an 8 or would you go with a 7 again?
I would go with an
To balloon again?
Yeah. We just balloon with a 7,
Yeah.
obviously.
I would honestly would just go at this stage to stenting. I wouldn't.
Yeah,
necessarily-
no,
Okay.
I agree.
So how would you size the stent?
It's a very high takeoff of the internal. Yeah, he's right.
I think that the proximal vessel's around 10 millimeters, and distally it's around 7. I think that you wouldn't be wrong using a 7.
And then post dilating?
Using a 10 bare metal, and I would dilate it to 8.
That's exactly what I was thinking. So give us a 10 bare metal stent. Give me an Abbott, what is it called? OmniLink. OmniLink, and then we'll go ahead and take care of this.
Yeah, one of the things that sometimes
What is the
people-
longest OmniLink we have, guys? Give me
So
a
Rami,
39.
balloon expandable versus self-expanding. Any preference here, or does
No,
it
you
matter?
won't see it. It's a lot of
Actually,
overlap.
PK and I were talking about that before the case.
Lot of overlaps, yeah.
I know,
You know,
39.
what would you do and when?
39.
For the common
sides.
iliacs, because that's usually a fixed part of the aorta, I often, if not always, will use balloon expandable covered stents. Also depends on the length. So if I'm treating from the common iliac all the way down to the distal external iliac, I'm more likely to use a Viabond in that situation because I can use a 15 centimeter
Stent first.
or even longer Viabond if needed. But most of the time, if I'm treating a common iliac with a covered stent, I'm using a balloon expandable covered stent. One, so we can deploy it accurately at the aortic bifurcation down to the iliac bifurcation. And
This is the balloon expanding.
if I'm stenting if I'm using a cover stent in the external iliac, I'm more likely to use a Viabond.
Deployed at 8.
Surgically,
Balloon expanding.
bare metal, 9-0 bare metal stents and Viabond stents can be clamped with a 40 hydrogrid clamp.
Measures enough.
So when I'm thinking, if I have to come back later and do a femoral endarterectomy on this lady, am I going to be able to clamp that artery? If I have a VBX in there, those are you cannot clamp a VBX. It will crush.
That's an interesting point.
Not yet.
We gotta talk a little bit about the trial from Europe that looked about balloon expandable and self-expanding,
self-expanding stent,
and and that trial showed no difference, Rami, in terms of patency, as long as actually a reduction in TLR in the balloon expandable stent arm.
Yeah.
So it's kind of interesting because I know I'm like you. I'm very biased in what I believe in.
Actually, clearly says that your balloon expanding.
What's going on?
Are you okay?
Everything okay? Yeah. Okay. So I just want to make sure the patient's not saying anything. All right. So it's going to be very hard to place this So we're gonna have to come up with a view that's gonna place this properly. So what I'm gonna do is we're gonna take different pictures.
Just
So
go AP, I think, would be.
yeah, I think AP maybe a little caudal. You think?
Yeah.
Let's see.
I think it's gonna
Let's
be
take a
both.
look here. I'm gonna do it on regular cine. Inject. Plus we have the calcium. You see we have the calcium.
Yeah, I think
So I
that's
would
great.
go right. It
little
looks
more
good
in.
right there. You want to go a little bit forward. I think a little forward, Arm, because you
Go a
see
little
the
in.
calcium is coming in on the side, maybe a little bit in.
Yeah.
Just
We have to
slightly
get
in
down.
here. A little more.
Flush.
That
more?
looks better.
Yep.
That's
I
good.
like that too.
You want to push the
little
pigtail
die,
down a little
die.
Push the pigtail down.
Pigtails all the way down.
All the way down.
Little die, guys. Okay, I like that. You?
Yeah, it's good.
All right, let's go up. So we're going to deploy this at 7 atmospheres. Going up, Liz.
ECT 303.
Okay. Breathe. Breathe. Breathe.
What diameter is this one?
This is 10.
10.
Just go to 7 atmospheres. That's at 7 atmospheres, right? No, 4 atmospheres. 5, 6,
Nice.
Looks well expanded.
7.
Yeah.
Very nice. Responding
7
well.
atmospheres. But now, remember, the idea is there's a little bit of a size mismatch down. So now we're going to leave the balloon there, and then I'm going to do an injection
Yeah, that's an
just to
important
make
point.
sure there's no perforation or extravasation. DSA number 2. We do it abdomen. Okay. Okay.
Wow.
No perforation. Internal is still patent. And you see you've got a 1-to-1 expansion proximally. Now we will IVUS afterwards, obviously, but you see the internal comes in afterwards. So your internal is good.
Now we should just do an oblique this
That's
way.
exactly what I'm going to do. So the view, watch your knees, please. You can see the oblique views are very important to look at the external-internal bifurcation here. That's a radial arm here. I'm just going to go 1 mag lower so we can see.
Yeah, that's good.
There you go. And I'm going to maybe a little bit better, a little bit higher, right there. Okay.
That's good.
Let's see. So, Sardar, can you comment on that study from Europe about that?
Looks good.
You mean the ICE trial or?
Yeah, the
Nice.
self-expanding versus balloon expandable.
I
The question. Go ahead. I'm going to listen to you.
I guess the Dr. Cameron has a nice slide presentation about all
Okay.
available trials.
So
If you can just show the
let's do that.
slides,
So what
because
I'm
they
going to
have
do
all
now
the
is.
Kaplan-Meier curves as well. So
Mic.
Is
just
my
in brief-
microphone on?
I'm sorry.
Okay, you can hear me. So what I want to do now is go to the study with Dr. Cameron. Let me just tell you what we're going to do for the sake of time. Me and Dr. Tadros and Dr. Guja are going to discuss about post-dilating. Right now, we're not sure whether we're going to post-dilate. We're taking it out. We're going to go ahead and do the same shockwave on the left side while he's presenting.
You're fine.
Okay, over the
balloon is
014.
not deflated.
And then on the left side, we're going to decide what stents we're going to place, which likely may be a VBX. Okay, go ahead, Harun.
Could you put up the
Turn
slide,
off
sir?
our mics here, please.
Next. Keep going next. Next.
Now, I'm not going to
Next.
post-dilate. Let's change that and do
Next.
the left
Yeah.
now. Right?
You're talking about it's a little crimped
Next.
down there?
Yeah.
I think it's okay.
Okay, keep going next.
Yeah.
Let's get us a
Next.
birth tip catheter.
The last thing I want to do is fracture that.
I think that's open, I think. Want to see
Next.
The side port?
No,
Side
no,
port of that.
it's okay.
Next.
Are you okay?
All right, let me just walk you through some of the stent options that we have available in the market. So we have balloon expandable,
picture.
self-expandable, and covered stent. Each one has its advantages and disadvantages. The balloon expandable has the advantage of a high radial strength at the expense of high likelihood of plaque shift to the contralateral side. The self-expandable stent has low risk of perforation, but at the expense of low radial strength. The covered stent are useful for excluding aneurysms and preventing new internal growth in the stent lumen, but the disadvantage is it excludes side branches with a high likelihood of edge restenosis. Can you go to the next slide, please? Okay, so let me just walk you through. Could you just give me, sorry. Let me just walk you through the ICE trial. This was a comparison between balloon expandable versus self-expandable stents. The inclusion criteria included Rutherford category 1 to 4. This was a single significant greater than 70% diameter stenosis or occlusion by the Doppler ultrasound of the common or external iliac artery with a lesion length ranging from 10 to 200 millimeters, not extending into the aorta or the common femoral artery. The comparison was between the balloon expandable VisiPro versus a self-expandable protege stent. The primary endpoint was binary stenosis at 1 year with a peak systolic velocity by Doppler ultrasound of 3.4 or greater. So the primary patency and freedom from TLR was significantly better for the balloon expandable stents in this study. Go to the next slide, please. So next study that I want to bring up is the mobility trial. This was a comparison between a self-expandable Absolute Pro versus a balloon expandable OmniLink Elite stenting system. So at 9-month follow-up, the major adverse events, restenosis, freedom from TLR was similar between both arms. The functional improvements were noted in walking distance speed as well as in stair climbing was significant compared to the baseline for both arms. Next slide. Now let me walk you through the COBAS trial. This was a comparison between the covered versus non-covered stent. The inclusion criteria for this study was task B, C, or D lesions, which are hemodynamically significant dissections and recurrent stenosis after angioplasty. The comparison for this study was covered stent, Advanta versus balloon expandable stent. The primary endpoint for this study was freedom from binary stenosis, defined as greater than 50% reduction in lumen diameter or stent occlusion by Doppler ultrasound, CTA, or digital subtraction imaging at 18 months. Next slide. For this study at 18-month follow-up, the covered stent was superior to the balloon expandable stent in terms of freedom from binary restenosis. Next. At 5 years follow-up, the covered stent was still superior in terms of primary patency and secondary patency. The predictors of primary patency included the type of stent and Rutherford classification at presentation. Next slide. So in terms of summary, the endovascular iliac artery interventions are increasing, including more complex lesions such as task C and D lesions. Careful case selection, workup, and planning is mandatory to achieve maximum success. Despite the reported safety of bivalvular, heparins preferred the anticoagulant. Various stents are available in the market for different lesion subsets with favorable long-term outcomes. Thank you so much.
Very nice presentation.
Good job, Sam.
So mic's back on, guys. Can you hear us?
Yes.
Okay. So I want to show you what we were doing. Karthik is going to just go over the images while we change out a wire, me and Rami. At the other
So we're just taking pictures from the ipsilateral side just to see the post. So we were concerned about one of the branches there, but it's a branch of the internal. You can see right below the stent. We saw kind of a shadow there. So, but it's a branch of the internal. We went back to the previous pictures.
Are you up?
At this point of time, any patients
Take it all the way
complained of a little heaviness, so we wanted to make sure everything was okay.
How far up are you?
So as PK was saying before, you have to watch out for every symptom the patient says, especially once you have not put a covered stent.
So a couple of things, guys, and Dr. Tadros and I really feel important about this. One is, okay, when you have a patient who's laying still, having no problems, all of a sudden she complains of something, after you've just done a CTO-iliac intervention, you know, you have to start wondering to yourself, why? I mean, could be stretch, could be these things. You know, the stretch and these things are not going to hurt her. What's going to hurt her is, God forbid, a perforation. Yeah. So we immediately went down, took a look, and also the image of the pre-op angiogram also helped us because it showed us that there was a branch or whatever, a branch of the internal that kind of looked fishy. That's what it was. So important to do your pre-op imaging before you go ahead and do an intervention always. Okay. So that's why we're not treating that. Plus, hemodynamically rock solid stable.
That's actually one of the advantages of doing these cases under sedation rather than general anesthesia.
There you go. That's it. Okay. So now what we've done is we've now changed out for the 014 wire, and both Dr. Tadros and I both feel that the left is actually more complex than the right because you have a common iliac issue and a very, very calcified external iliac. So we're going to shockwave again. Can we use the same balloon, Mike? We can use the same balloon. So Dr. Guja is going to prep the balloon, and we're going to go ahead and shockwave both. Rami, in terms of the fact that our sheath is this distal, because we can't cross the external iliac lesion here, and the first lesion is around, say, by 16 or 17, the question is, would you treat the distal to the proximal or proximal to distal?
I would still treat proximal to distal.
Yep.
And what we can do, treat proximal to distal, and then as we deflate the balloon distally, we can swallow the balloon so we can get our sheath a little higher so that when we treat the common iliac, we're a little bit more proximal.
Are you concerned about swallowing the balloon over the 014 wire? Because obviously very calcified area.
No, I'm not worried.
Should be okay if we expand.
Yes.
Yeah, I think the key there is the expansion, guys. If we have expansion, we can even inflate the balloon and then just hold the distal. Yep. We can even what is it called? Telescope using the balloon as a dilator. We can go ahead and telescope the balloon.
Straighten everything out.
Yep. So Dr. Tadros is not going to go around. It's around 15, 16, 17 in that area. This is a 7060 balloon, I believe, right? So it's a 706.
You have a 7 French sheath on the left side?
Yeah.
You go way up. Exchange the balloon back.
Probably already.
Yeah, it's so tight. I'm telling you, this is so tight.
Yeah,
There it goes. Look at that. Look at that. It's so tight. Believe me, I know. I was trying to. There it is. That's the lesion. Perfect.
There it is.
Good. So now we're going to go up to 4 atmospheres.
She may feel.
And you have 300 seconds of use, right?
Yes, we have 240 seconds left.
Left.
Would
So we
you,
have
would
200
you, I would probably go a little bit more in because the center markers is where the maximum intensity is. So if you think your lesion, the tightest lesion is around 16, you might have to push the balloon a little bit higher up to give that maximum effect.
I agree. We're just going to go up and look at the balloon mark. Oh, it's split up.
If you can go.
Yep. So
See,
we're going
at
to go
16,
up now.
you're right. Yep. That's a good position. I like that part.
So we're going to go ahead and press and hold it. There, you can see. There it is. He expanded. See that, guys?
Wow.
Filtered.
Good job,
Fluorescein?
Karthik.
Fluorescein.
Yeah, I know.
Your right arm now is bothering you?
Yeah, there's some lesion in at 17 as well, which I guess will be treated later on.
So an interesting question for every user of the shockwave in iliacs is how strong is the evidence for the use of shockwave in this type of lesion.
You want to go one more down? I think it's
If you look to the literature right now, there is only published series from, I believe, from Italy, from Carlo Di Mario. There is a 4 Italian and 4 American center combined.
Why don't we go up right there? Go up again.
Published in JAC Intervention last year, showing the feasibility of doing shockwave in iliacs before TAVR and AVAR cases.
Okay. And I got to be, I think that's a great point. But, the beauty is I think everybody gets their own data. And obviously, we're a busy center. We have great collaboration, thank God, during my career here. And I think that the beauty here is that, like what Dr. Tadros putting together this series, which is really a multidisciplinary series with everybody involved, I think it's going to add to the literature. But, for them to do a randomized trial, the endpoints are difficult. I think it's also the power may be difficult to find out, because there is no real data saying which iliac is going to perf and which iliac is not going to perf. And so, it's going to be hard. But I agree with Serdar, where a multi-center registry may definitely help us, because the multi-center registry would help us. And we've actually spoken to Shockwave, and we're going to obviously work on this with Dr. Tadros to try to get this, because, no, we're not done yet. Right there. Okay, pull the sheet back slightly, maybe.
Yeah.
Yep. So we're going to pull the sheet back slightly. Good. He's going to go up to 4. So this is the one we're really, really concerned about, obviously. That's good right there. He's at 4 atmospheres.
Yeah.
Going up now.
Look at our bladder.
So, there it goes.
So
Look at
this
that.
is like 5th time. Yeah.
Huh?
Wow.
Look at that. That's amazing. Look at
Save
that.
that, guys.
That's very nice, yeah.
Yep. Save that, guys. Flora, save that.
Flora safe.
So now
That's at 4 atmospheres.
That's at 4 atmospheres, and obviously the pulses are going. It works very, very well. So now the question is, do we do a Viabond? Do we do a VBX? I mean, maybe we do a bare metal self-expanding at the external and a covered stent at the ostium may be the right thing. That's what I want to do. And take it from there. Do it one more time here, Rami.
Expansion looks good,
Right?
so it looks like it's bare metal.
Yeah, I mean, that's, I
What do
guess,
you
the
mean by
most
reset?
critical question.
Okay,
I
reset.
mean, the expansion is fine. If it's expanded very well, the lesions have expanded very well, you can go with the bare metal this side too.
No, I think up top I want to go with the covered. I really do,
guess
because the internal is not involved there. I think it's really eccentric calcium. I know we shockwaved it, looks good, but I feel at this stage a covered stent on this side and maybe a bare metal self-expanding, if it expands well with balloon on this side, would be nice. If it doesn't, then I think Dr. Tadros' idea of going with a Viabond distally may not be a bad idea here, since it's the external. She doesn't have common femoral disease, Rami, down. So I don't think she's going to need any further surgical intervention. Now Rami's going to go ahead and sheet this now. I'm going to rail this for him and see how this goes. Right, so there he's sheathing it. This is where it would not cross, and still is not crossing.
Give me inflate the balloon one more time.
Inflate the balloon, Chief.
Just like 2 or something.
And then deflate it.
I'll
So
go
this
two,
is
you
the
can
this is
do
the
it from
balloon
the sheet.
inflation deflation technique we use in the coronaries a lot. So he's going to go ahead and deflate
Go
it.
ahead and deflate.
Deflate, and he's going to just try to push it across. Nope, not going. So we're going to have to switch out. So we'll switch out. Again, it's a nice, smart technique to try, but also know when not to do it, obviously if you have resistance. Let's go ahead and get the 035 catheter. We're going to switch out. I'm going to do a pigtail angio where they switch out from above to make sure there's no perf. Let's go ahead. Look, the bladder is quite full.
See, that's why in these cases, like me and Karthik were talking about getting the radial access for good visualization. So I think it's very important, like Sardar talked, visualization. So I think radial in this case, the third axis really helped us to exactly see if there are any issues to begin with and to anticipate any complication that might happen post-procedure.
Syringe.
So always good to have the third hole in the arm just for a good view.
Sorry.
Yeah, and always flush. Be meticulous in your approach.
Right.
So we flushed it now. We know there's no issues going on, and now we're going to go ahead and just do our injection from above. Oops, sorry.
Step away.
Sorry, Rami.
It's okay. Yeah.
Okay, very nice. So now we're going to just go with the 035 wire. Let me take a little bit of the radiation from Rami, because there's a lot of radiation, as we all know. And we'll go with the 035 wire here.
The bottom one might need a covered stent.
I think both are going to need a covered stent, but I think
It's okay.
I don't know. I mean, the bottom one expanded really nicely. Do you really need a covered stent? I don't think so.
I think honestly,
I think there's a little bit of residual around.
The problem is we're going to have to upgrade to the 8 French. I keep telling Mike Ligori from Gore that this company has to come with smaller stuff.
I think 839
and
fits this.
unfortunately, Mike, as much push as he has with Gore, pull it out, is
839
not
fits.
able to do anything.
we could
Mike,
do it through a 7.
yeah, you can do an 8 French
We can do an 8mm low profile.
through a 7 French.
Through a 7 French.
But do you think 8 is big enough for this? Because that was
for the external, not for the.
Right.
If you want to do I would do 7 or 8 for the external.
Right.
Low profile.
Okay, good. Walk it out, bro.
If you're going to use a Viabon.
Well, to me, I would like to use a bare metal stent on the external if I could.
Which is fine.
And I think up top we use a nice large covered stent.
And I think we can do that through 7 French as well.
Yeah, that's for sure. Yep. Yeah. So give us a 70. What do you want? 59 VBX from above, please. Flora.
Let's take a look and see if that's going to be
Flora,
too
bro.
long or not.
Might be too long. Yeah. Let's mag up a little, Chief.
59 would be probably too long.
It looks like too long, but we're going to take a picture. Yeah. Okay, ready? DSA?
Right. DSA, sir.
Inject the Cine. No, I think it may be good.
Might cover the internal, though.
Really?
Unnecessarily, yeah.
Open the 759.
Where's the internal takeoff?
And go through that frame by frame. Can you pause it?
Yeah.
No, but remember the initial lesion was involving the internal, though.
Pause that.
Oh.
You go frame.
I would probably prefer to put in a longer.
Yeah. I think you got to cover it, man.
What do you need?
Pause it. Let me know.
So you're okay
you want
covering
me
the
to pause
internal
it?
on the left side?
I'm not okay with it, but I remember the lesion. Can you go to my first shot, please? Go plus all the way to the front. I want to show Rami. And this is part of the importance of really keep going. I'll tell you when. Keep going. More. This is part of seeing it. This is the other side. The other, keep going.
It's actually
See right there. You see that?
Yeah.
You see how the internal is lower?
Yeah. But if it well expanded with the chocolate, I would probably. I'm more concerned about the distal
It's
external.
involving the internal right there.
Yeah, I see it.
You see it? How it's involving the internal?
Why can't you just put a bare metal here also, PK?
Yeah, I know.
Especially
Why
if
not
it's
put a bare
involving
metal
the
here?
internal, why not just put a bare metal here?
It expanded well with the
Yeah,
chocolate.
it expanded very well. No, I don't see any unexpansion. Actually, it's better expanded on the common than on the external.
I agree with Karthik. It's better expansion. So
then we'll use a Viabon on the
external.
Do that?
Just
Sure. Because
All
you
right,
have to
so
crack
give us
the
another
external,
Abbott
because the
stent.
sheet didn't go through. the external.
Another 10-0. What do you want? 59 or 39?
39 is fine. You can take it.
What do you think?
I don't think it matters if what
probably
you
go
take
longer.
because it's longer
I
is
go
better,
longer
right?
rather than smaller.
Longer is
59
better.
is good.
59.
Yeah,
I'll take a longer
cover
one.
it, so.
10-0, 59. If we have it,
Omnilink, yeah.
we don't have it.
39.
We have a 39. So God has mandated that we do 39. So we're going to mandate. The God of Mount Sinai ordering has mandated that we do 39.
Big IMA, if you see that. That's
Yeah?
one of the telltale signs of aorto-iliac
10 or
disease.
39. 10.
Oh, yeah. All right, we're going to go with the 39 because we don't have a 59. I'm sorry to tell you.
We'll be okay with that.
I think we'll be okay. So this view, we're going to do it on this view. This is a LAO 23 caudal 1, which is perfect, Flora. And now let's increase the power to 1,000 PSI. and make it 10, 20. 10. Up. 10 and 20. Oh, 30 is fine. I don't care. 20. Okay. All right, great. So now we're going to do a fluoro. Fluoro for me. Let's do a nice DSA image. Ready? DSA. Cindy? That's all saline, I guess.
Yeah.
Do it again. This lady is tough cookies. Flora, save it. Pixel shift it, please. Flora, save. I mean, do this stuff.
Yeah. Will do.
I think
Right
that's
there.
good enough.
You can
Yep.
see it right there.
You can see it right there. All right, give us a 39 now.
We're at the 16.
16 or so. That's what I saw it before.
Yeah, I
think
know
common.
it's probably going to run right at the junction. Yeah.
Mm-hmm.
Okay.
So real. So Rami, let's talk about a little follow-up on this. What do you do in terms of follow-up on these patients? Ultrasound follow-ups. Right there is good, huh?
Good.
I think it's pretty
No,
good.
usually
For
this
the ablation, they're waiting.
Go, go, go.
usually this area.
That's pretty good, no?
Yep.
Yeah.
You like
You
it?
can go in a little bit
So
also
this is a
if you
10.
Higher.
You can go in a little bit also. Because
Common.
Why is that bleeding that
It's
much?
just through the valve.
so the sheet can.
Flora?
She's okay. She's okay. That's good right there. I wouldn't go any higher than that.
Okay. Go up.
I'd even come down a tiny bit, actually. Stop it. I would come down.
Flora? Flora? That's
Right
good.
there. Perfect.
Yep. Go
That's
up.
perfect.
So you were talking about
Follow-up, I think
just be careful. Go
this
to
area should be visible by duplex.
Yeah.
And we have, as long as you have baseline physiologic studies to compare to, you can see the waist there.
Wow.
I think that's,
What are you at right now?
4,
Something
4,
like
5,
Pre-del, something. The chocolate is
7.
Pre-del.
7,
What's nominal?
8.
Go to 8. Okay.
That's good.
11.
That's good.
9. 9 is good. Down. Again, enemy of good is better, right? Go up again.
Yes.
Enemy of good is better. Go up to 9 again. We're just getting rid of gradients, guys. It's a claudicant, right? Getting rid of gradients. We're not making the artery beautiful. There's no value here other than complication to make the artery look beautiful.
I think for the external, would you use 7 or an 8?
You know, to me, I'd rather go bigger rather than smaller, Rami.
8 is
Yeah.
fine.
If you can get an 8 through here, I'll
It's a
be so
large
happy.
artery. 8 is fine.
Okay,
Look,
get an
Lori,
8
you have a,
8 to 8,
you have an
39.
8,
39 or 20.
oh,
39.
you think
down.
50 or
Bye, man.
100?
I guess an
You have
important
LP?
question for
Right.
all
Yep. Do you have a
structure
structures,
is,
Viva? This side.
8 low profile?
Yeah,
8,
go ahead.
Bring an 8,
Farhan.
10, and 8.
Sardar, go
important
ahead.
question for all, maybe from all, a lot of structural
We have it in the OR,
heart disease,
right?
physicians is
How about pre-del?
how safe is it to go in with a 16 French sheath after stenting these lesions?
Well,
When-
I can
when
answer
can you
that,
perform
Sardar.
it?
So last we've been doing that now. We should write up our series. So we've done now about 14 stents of VBX as well as the bare metal stent, in which they've gone through both here and other institutions. And I can tell you that it actually performs quite well as long as you get a minimum luminal diameter of at least 10. This is what I feel. When it's 8, I've asked them to balloon dilate it. Beautiful. When it's 8, I've asked them to balloon dilate it. But when you get it up to a 10 like this vessel is, it's been fine. We did one yesterday for Dr. Sharma and Dr. Tadros. I'm sure they're going to do it. So that would be another example. Rami, in your experience, how safe is it? Flora?
In terms of passing large bore sheaths
Yes.
through these stents?
Yep.
I think the longer the stent's been in, the safer it is.
Right.
At least the stent will be incorporated.
Yeah, at least a month. Yeah, exactly. But a month is too short. I agree.
Yeah, but yesterday we did a TAVR where we had a small vessel, 4 millimeter vessel, and despite ballooning, lithotripsy, everything, we still had a really hard time getting our sheath into place to deliver the valve. So actually, what we did is we put an 8 millimeter Viabond from the common all the way down to the distal external.
DSA.
We used high pressure balloons to essentially purposely fracture the artery. And then through that, we were able to pass the Edwards sheath, which is 14 French, and that went well. We
With a
had
freshly deployed stent.
through a freshly deployed stent, but you got to watch it as it goes up. We call it a crack and pave technique in our world, basically, where you purposely fracture the artery with a covered stent in place.
It's an 018 system, right?
I think that you need at least an 8 millimeter stent. I wouldn't go smaller. We had a case
Air column
where we used a 7 millimeter stent, and
7.5.
sheath got fused to the stent, and we ended up with a major iliac injury, pulling the sheath out. So
you know, I got to tell you, all this stuff. So we have a large bore access session in our symposium. Rami is part of that symposium and is actually, I think, is giving a lecture, if I can remember right, on this Shockwave technology. We've also got Mazen Fote, who's running the Terumo trial on large bore access, and obviously we've got Torsten from Colombia, who's actually going to go ahead and talk to us about using dual perclose technique. And we also have our Manta. I'm sorry, he's doing the Manta. So the point is, we've got a lot of people. We need an 018 wire, guys. We got a lot of good people to come, and there'll be a very robust discussion on this. What's going on?
We need an 018 wire.
We're going to inject directly. Okay.
Yeah, let's get an 018 wire.
So what's the plan for the external distal? Covered or best
covered?
Self-expanding?
Yeah, we're gonna do a covered. I mean, to me, you could do a self-expanding. I mean, that's what I feel. But I agree with Rami here. You've maybe a crack and pave. We got to change out the wire, guys. Crack and pave may be a smart thing here because there probably is a little bit of recoil going on despite the shockwave. So we're gonna put an 018 Viabon. Again, Rami, when you're doing Viabon near the common femoral, I know what I look for. What do you look for in target-wise in terms of anatomic landmarks?
I usually land it. If I can land it just above the epigastrix and preserve the epigastrix, I like to do that.
It's kind of what we do too. And what about the top of the femoral head sometimes because of extreme, you know, you get some people.
BBX I think is a good stent.
Oops.
What's the?
Watch as
you
go
through
that.
Yeah. Okay, show me above.
The VBX is a very flexible stent, and you know you can pretty much tie the thing. I'm sorry, the Viabon, the 018 low profile Viabon. Both are very flexible. The difference between the VBX and the regular Viabon is that the Viabon is self-expanding, and therefore it resists compression, especially at the inguinal ligament, where you may have flexion there.
So now we're going to go ahead. Time check. So this is a classic example. Walk this out. So he's an incredibly complex case. We're done in an hour. You know, and I think part of that is the planning, is the discussion, is the thought process that works in order to get this done. So right now we were fortunate enough. I mean, we have Dr. Tadros here who's helping us make some incredibly difficult decisions in sizing as well as in choosing the right equipment. So right now we're going to go ahead and place the VBX down. The Viabon down below. It's an 8.0 low profile Viabon that we're going to go ahead and place. What's going on?
It's not going. Still air column.
Air column. Why is there air column, Damien?
Okay.
Why is there an air column? So
I got it. Go.
Okay, so we're just going to go ahead and hand inject, but Damien's going to fix the air column for us. Sure. She has to go to the bathroom, team. Okay. Okay. Go, sweetheart. We'll fix it. Don't worry about it.
1 second, Damien. Let's finish.
Go down to 20, just beyond 25, maybe
Yep,
26.
that's exactly what I was thinking. That little bend was the tightest spot. Yeah. See, but Rami, this is where I worry about this VBX because the Viabon, because the radial strength is very poor, and one of the things I worry about is at that level with is that bend with that eccentric calcium. Would we be able to expand? I feel better that we've done the shockwave, but at the same time, you know, this is a worry for me personally.
Yeah.
You know,
I think you use a high pressure balloon if you have to.
If you have to, right?
And you have the protection at least of the.
So what's the incidence of ripping the material with a high pressure balloon?
I mean, if you're undersized.
How's that?
Yeah, it'd come down a little bit actually.
Yep, I'm just gonna pull my sheet back slightly.
Bring the stent
right
down
there.
a little bit lower. Right there, perfect.
Right there. All right, now Karthik, you want to go over the deployment?
Yeah, just pin and pull.
Slow pull.
Slow pull. Especially the initial one.
There's a space between the stats. There's a space.
It doesn't foreshorten, right, Rami? And
very little.
No, very little foreshortening. It's not like a balloon expanding one where there's a foreshortening here.
I've never seen the fabric on a Viabon tear.
You haven't, okay.
I've not, and I've deployed hundreds and hundreds of these, and
Right there it goes.
That said, if I have an 8mm Viabon, I'm not going to use a balloon that's bigger than 8.
Beautiful.
That's perfect.
Okay, off-road map here.
So that was 7.5 centimeters long.
Okay, give me a 6015 Viatrac balloon or a 7015 Viatrac.
You can take an 80 also. Or you can take a 70.
I think
70
I would
seven
do 7.0.
Yeah.
70 is fine.
7.0.
So here I'm going with an 0-4 balloon of Viatrac, just because I have an 0-4 wire up. It saves some time, and Dr. Tadros doesn't worry if I spend too much money on this case.
No, it's not our budget. It's Cath Lab's budget.
So we're going to go ahead. Actually, that's a good thing to talk about, Rami, because iliacs are very expensive to do.
Yeah.
But at the same time, they also don't reimburse as well as other areas.
Yeah.
So, we use a lot of expensive equipment here.
Yeah.
And, I think, any comments on that? I know we're trying to make patients feel better, and so on and so forth.
I think at the end of the day, you got to do what's right for the patient.
That's what we do. Exactly.
You know what I mean? I think that
it's a monorail
cost
balloon.
is an important consideration as long as it doesn't impact patient care.
So one of the things that we do is we look at whether we're doing it, Flora, for show or for the patient. Because a lot of times what happens is when you do things just to show them, it becomes an issue. Let's go up here, guys. So the point is, one of the things with the Shockwave balloon is great balloon, great technology, not reimbursed, very expensive. But here, I truly believe the Shockwave balloon made a huge difference in the ability for us to treat this patient safely. So, that's what Dr. Tadros is saying. You could have argued with me, well, we don't need a cover stent outside external. You're probably right. But eccentric lesion, I don't want to deal with a perf. Yes, I did Shockwave, but anything can happen. So at this stage, that's kind of the reason why we went here with different technologies to show you how you can marry each one. Okay, nice expansion down. Let me walk this back. So this is nice. It's an 0-4 balloon. Go up here, and it's an old renal balloon that we've used, all of us old dogs, for many years. Down.
The fluoro.
Right here. So he's just going to 10 on each segment here and expanding.
Actually going to 14.
14. Okay, which is fine.
It's covered stent.
Right here. Yep, it's a covered stent.
That's what gives you the ability to go dilate.
Okay.
So that's what she felt at the lesion.
That's the lesion. Yep.
Yeah,
It's a covered stent,
I would let
so-
the pressure stabilize there.
Down.
Really get that pressure up.
Cycle of cuff, guys. Good. Stabilizing.
Yeah, good.
There you go. Down. So now I'm going to try to track this sheath in Flora, please. So just to make sure that if I did perf, I have my sheath under control. Yeah, should work.
So you don't catch the edge.
Yeah.
Let's put the dilator in.
Dilator. Yep, walk this out.
0-4.
Yep, I agree. Okay, let's inject, guys. Let's take a cine.
I think we're going to be good.
DSA? DSA?
Pressures is normalized on this side. There's no gradient anymore.
Okay.
Call him again.
This is our assist device, which is
Probably shoot from the.
Yeah,
I'm
that's
sure
from the
Karthik
sheet.
can generate a PSI of 1,000, right, Karthik?
All right.
Rami is here in the room. Why do you need me to generate it?
Hold this.
He can compete here. With
All
me,
right, put a dilator on that, guys. Okay. Cine.
Wow.
Even the old man can generate a reason to PSI. I got these young bucks now. Where's Peter Ferries when I need him? I got these young bucks next to me. But I think this is a good result. We'll just put the dilator up and take a final picture, and we'll sign out. But
Well, we have the radial sheath, right? We can just shoot from above.
yeah,
no?
that's a great idea. I forgot totally. So we're gonna take a final picture here. Let's do DSA, guys. 10, 20.
Nice result.
10, 20,000.
Is the injector working?
Is the injector working, Damien? It's still not working. I need the injector to work.
Okay.
Portfolio, I can't inject from above with the radial sheet.
I got it.
No, bro, you're not going to see.
Not going to see. Inject
gonna see. It's too
bilateral
much work.
iliacs.
No, come on.
Rami does it all the time for AAAs. Yeah, we do it all the time for AAAs. Yeah.
It's not like a iPad.
There's a lot of
You gotta
flow
hit
here,
above
dude.
it.
All right, you ready? Oh,
We have
close
to
to the
good right.
patient.
Better stand away from the beam.
All right, let's try it.
Okay, come forward. Okay, flush forward. Okay. All right, my dear. We're gonna have you do a couple of exercises here.
Less mic.
Take a deep breath in.
You want less mic?
Yeah.
One less mag.
One. That's perfect. Take a deep breath in. 10, 20,000. Right?
10:30. I got.
Okay, good. Let it all the way out. And now don't breathe, don't move, don't swallow.
Don't.
Beautiful.
Stay on for a long time.
Excellent.
Okay. So, I mean, breathe normal. So you can see here.
Very nice.
Wow.
Internals are patent, externals are patent, and obviously a fantastic case using marrying different technologies.
One thing we didn't really talk about is whether you do kissing stents or not at this location. I mean, we on the right side, we landed right at the aortic bifurcation.
Yep, beautifully.
When do you consider that, PK? When do you consider kissing stents?
You know, I generally, if there's no lesion on the opposite side, we may balloon protect, but we generally don't kiss. We've done balloon protection before, but either if there's no obstruction, you know, the chances of occluding the other side are very, very low. So yeah, we generally don't. If there is any sort of reason, like even a 30, 40, 50% lesion that may cause some significant plaque shift, then we do kiss.
Yeah.
Especially if you're using a balloon expanding stent on the contralateral side, you can nail the ostium very nicely.
Yeah.
Very rarely that you will.
Yeah, I think either
of the stent, so
I think either
doesn't splay.
I agree with PK. I think that if you can nail the ostium at the aortic bifurcation without having to put kissing stents in an aortic bifurcation without substantial disease.
No,
I think just posted you have more disease in the aortic bifurcation, disease in the contralateral side, or even on the ipsilateral side that's almost like encroaching onto the aortic bifurcation, then it's more valuable technique.
I mean, honestly, Rami, I can't thank you enough. I know our team, the patient appreciates you taking time out of your schedule. You know, thank you so much, Dr. Turner. It's a pleasure. You know, for the audience, Vishal, before you close, I just want to say that this is an example of really the future of endo. I mean, you know, we collaborate, we learn, we work together for the good of the patient. And I think as long as that open channels of communication are there, everything always works out well. And the truth of the matter is there's so many patients out there. There's no reason for us to, you know, argue and fight over silly things because, you know, everybody can be equally busy. But I can't appreciate Dr. Tadros. I mean, he's probably, I mean, I don't want to say anything like that, but he's one of the busiest vascular surgeons here at Sinai. And for him to take an hour and a half out of his morning schedule to come and help us and teach the audience at home. Also for the audience, thank you for all the wonderful questions. Keep them coming. You can also email Dr. Tadros at rami.tadros@mountsinai.org. Any questions on the Shockwave thing that he's pretty much in this institution pioneered and led. You know, any questions you have and any questions on large bore tracking and so on and so forth. He works very closely with Dr. Sharma Kinney, our entire TAVR team. So again, from here, from the Cath Lab, we're gonna sign off. We'll see you next month. We have another incredible case planned for you, but I think this case illustrated all that. So thank you, Sardar. Great job on your first moderation, and we'll see you soon. Thank you.
All right.
Thanks, man. Can't appreciate you enough.
Anytime.
Okay. Thank you, PK and the team, for a great case. Thank you, everyone, whoever got an opportunity to join us. For people who couldn't really get onto the live webcast, you can go to our archive section on our website, ccclivecases.org, and you can log in and see any of our previous cases and this case as well. Just to reiterate that our annual endovascular conference, the nyevs.org, the New York Endovascular Summit, will be held on April 29th through May 1st here in New York City, Manhattan. Please register, come visit us, meet people, exchange some ideas, and hopefully you'll learn much better and get some latest information. Next month, we'll be back again for another case, March 25th, 8 o'clock Eastern Standard Time. Till then, I, Vishal Kapoor and Sardar.
Thank you very much.
Thank you for joining us, and have a pleasant week and a month ahead.